Hi, I'm Amber Shada. I'm an assistant professor of surgery at University of Wisconsin, and I'm talking today about flexible endoscopy forums and a case posted about endoscopic identification of leaks to permit endoscopic therapy. I'd like to thank Drs. Chen and Idley for allowing me to give this talk. My disclosure is that I have an educational honorarium through Medtronic. My case is a 69-year-old female who in 2014 had a lapsed sleeve gastrectomy for morbid obesity. She developed GERD and was later converted to a robotic Roux-en-Y gastric bypass. She also had a hiatal hernia at the time that was repaired with a mesh, and her anastomosis was performed with a circular stapler with the gastrotomy closed with a Stratafix. She did fine post-op day 1. She underwent an upper GI, in fact, but had no leak. However, her course was not smooth. She had intermittent episodes of tachycardia, and ultimately on post-op day 5, got a scan that showed a leak at the GJ and some fluid around the GJ. She was taken to the operating room. She had a laparoscopic, which was converted to open take-back. There was a posterior and lateral leak identified, and it was closed primarily with silk and then an omental patch laid at the top of it. There was an external drain placed and then a feeding J tube placed. So post-op day 29, she had a repeat upper GI. She still had an ongoing leak, and therefore a stent was placed across that leak. Post-op day 39, she had repeat imaging that found stent migration into the roux limb and an ongoing leak. I met her on post-op day 44 and went and got her stent endoscopically out of her roux limb and could not find a mucosal defect at her GJ anastomosis. It had been a few days, so I elected to restudy, and this is the result. There's a small pocket of extrav contrast next to the GJ. So I posted the case to get help trying to find this defect. So here's my post. I wanted people's tricks for finding an anastomotic leak endoscopically when I couldn't see it, but I knew it was there. So the endoscopic hive mind chimed in and had some suggestions for me. Just remove the drain, take the drain out, it'll heal. Inject the drain with fluid, just saline. If the drain's old, you can take the drain out and wire it, take it out, and then put a scope. Put a sphincterotome, and then a wire probe, and probe the probable tract from the endoscopic side, fill the pouch with water, inject the drain with air. Inject methylene blue, dilute to methylene blue, then hydrogen peroxide. Lots of helpful suggestions. So what this did for me was it gave me a game plan of what I was going to do when I went in there. So I elected to have a plan that was inject the drain, then inject the drain. So start with saline, then inject with methylene blue, then insufflate through the drain, then wire the drain, and finally, if all else failed, just take the drain out and hope for the best. The sphincterotome is not something that I can do. Ultimately, in the OR, all I had to do was steps 1 and 2. It was really nice, though, to have several backup plans for if that did not work. So I went in endoscopically. I was able to find the leak by injecting methylene blue through the external drain. You could easily see blue in the lumen. It required some forceful injection, but it worked. Through that defect, I then placed a double pigtail stent, just like the picture shown here. So I essentially internalized her drainage. So she had her external drain removed following placement of this double pigtail. I then transitioned her over to oral intake. She was not using her J tube after several weeks, and so we took the J tube out, and then ultimately the internal drain was removed. So the course chairs have asked me to speak on data. I couldn't find any good data about this topic. I also am pretty sure there's not good data because Dr. Teitelbaum, who is the best at providing data, did not provide data in this case. Instead, provided his anecdotal thought. So I think I'm the only person at my institution who does this kind of advanced endoscopic stuff, and it's really nice to have someone else to bounce these tough cases off of. So I think using the hive mind to figure out what are all the options for treating things. Am I thinking outside the box far enough? And then also, in this case specifically, I really relied on them to remind me of things that I knew and I had done before. I definitely had in my toolkit, or they were rusty and I needed to pull them back out. But at the end of the day, it's sort of just, it's like having thousands, hundreds of partners out there helping you with cases. So thank you for your time. And I hope that you are able to use the Facebook groups yourself for some complex cases.